Hello class, my name is Oscar Paz for HIM 5363. The topic I will be presenting over is data mapping. These are objectives that will be accomplished through the presentation. First, we will understand the meaning of data mapping and associated concepts. Second, we will determine the effectiveness of general equivalence mappings. Third, we will evaluate the mapping of SNOMED-CT to ICD-10. Fourth, we will understand the impact of errors on data mapping. Fifth, we will review the impact of data mapping on healthcare. Introduction. Data mapping allows data that was originally used for one purpose to be used for another purpose, and they allow the translation of data from one classification system to another. Data maps are directional and can be forwards or backwards. Classification systems allow for the categorization and aggregation of data. An example of a classification system is the International Classification of Diseases, or ICD. And another is the Systematized Nomenclature of Medicine Clinical Terms, or SNOMED-CT. General Equivalence Mappings, or GEMS, are published by the Centers for Medicare and Medicaid Services and Centers for Disease Control and Prevention. GEMS are guides for translating between ICD-9 and ICD-10 code sets. Now we're going to look at a study that investigated the effectiveness of GEMS. This study used 100 primary care notes and asked professional coders to code the notes for ICD-9 and ICD-10. The GEMS that were compared were forward GEMS, or ICD-9 to ICD-10, and backwards GEMS, or ICD-10 to ICD-9. Of the 100 cases, coders identified 598 diagnoses. The table to the right shows the most common manual diagnoses used by the coders. You can see that the most commonly used codes for one version of ICD also have their translation on the other version, such as hypertension in the first row. The first column on the graph shows 85.2% consistency of manual coding with forward GEMS, and the second column shows 90.4% consistency of manual coding with backward GEMS. The investigators of these studies state that these results should reinforce the notion that no true crosswalk exists between ICD-9 and ICD-10. Now we're going to look at a study that evaluated SNOMED-CT and ICD-10 mapping. This study used guidelines developed by the National Library of Medicine, or NLM, for the purpose of translation from SNOMED-CT to ICD-10-CM. The authors introduced SNOMED-CT as an interface terminology that clinicians may use to capture data in an electronic medical record system. And ICD-10 was introduced as a code set for billing and payer reporting. The mapping by the NLM has advice in human-readable format that provides suggestions on considering additional ICD-10-CM codes. The NLM intended the maps to be used in vendor software with rule-based engines that would use algorithms to evaluate contextual information, such as patient age, gender, and comorbidities. When the investigators implemented the NLM map onto their electronic medical record system, some of the challenges they faced were the presence of similar SNOMED-CT concepts and atomic or independent concepts having different mappings than their pre-coordinated or complex concepts. and disproportionate mapping rules that are challenging to map to the target codes, and clinically insufficient mapping rules that may leave out information, and mapping system inconsistencies such as different rules for different body parts for the same condition, and the existence of maps for problems that don't necessarily determine the treatment plans. Some of the recommendations by the authors are to carefully select SNOMED CT terms to put into problem lists. The mapping of SNOMED CT to ICD-10 should be considered a foundation, which should have its rules expanded or collapsed. Facilities that are looking to expand their mappings should explore associated SNOMED CT terms. And there may be a need to create local maps since some SNOMED CT terms may not have NLM mappings. Finally, the authors conclude that NLM mappings are a starting point and that they must be modified. Next, we're going to look at a study that investigated how spelling correction impacts mapping of SNOMED CT. This study used Swedish medical and clinical text to carry out its investigation, and it used sources of information for carrying out spelling tasks. One being medical literature comprised of journal articles, and the other clinical text comprised of electronic health records. Correcting misspellings were carried out by two tasks, one being identifying the misspelling and the second is the spelling correction. The graphs to the right show the results the investigators found. The top graph shows results when using the medical literature source, and the bottom graph shows results when using the clinical text source. The horizontal axes are the amount of misspellings, and the vertical axes are the types of algorithms performed. The red and blue coloring represent separate evaluations carried out by the investigators. The most important observation from these graphs is that there was a positive percentage increase in every algorithm or method that the authors used to map misspellings in their sample of clinical text. Another important result to take from these graphs are that the number of mapped terms are greater by using the medical literature source than the clinical text source, as seen by the higher percentages on the top graph than the bottom graph. These results show the impact that spelling can have on the reusability of data. Summary and impact. Mapping allows for the translation of data. Mappings are not perfect, as we saw in the first study, where GEMS did not have 100% consistency when compared to manual coding. Maps are not absolute, as we saw in the second study, where mapping rules may result in insufficient information, thus requiring refinement. And mistakes such as spelling can influence whether or not terms are mapped. The impact of the information that was presented can be helpful to healthcare systems as advice for having professional coders and other healthcare professionals to review maps for completeness and have them provide feedback on how maps can be improved to meet the coding needs of a healthcare organization. Additionally, improving data maps should be considered investments because improvements can influence the future reusability of data. These are the references to the research presented, and this is the end of the presentation. Please leave comments or questions in the forum. Thank you for watching.